Hello, ladies and gents. I'm RN Glenn, aka Nurse Dad, former Navy Hospital Corpsman, current ER nurse, and host of the Nurse Dad podcast, available on both YouTube and Spotify, and very soon Apple Podcasts. And I have the honor of speaking with Dr. Kahan. Doctor, thank you for coming on the podcast.
Thank you so much for having me on.
I talk about a lot of things today with a focus on menopause. And this is a topic that I was really excited to talk about. And someone might say, well, what does a 44-year-old man have to look forward to talking about menopause? And very simply, I'm connected to women that I love. And my mom, which I want to mention her story to you, menopause is illustrated like a storm that every woman has to confront at some point. And I'll use like a tornado. And it's kind of like, hey, maybe it'll take your house. Maybe it won't take your house. Maybe you'll go through it and it won't hit you so hard. And that's how it's presented. If we even talk about menopause at all, I think the consensus I get from the women in my life is one of like powerlessness, almost like it's going to come to you, it's going to do what it does, and your options are not plentiful. But what do you think about that?
Well, I like your analogy. I mean, if you know a woman, then menopause should matter to you, right? If a woman lives long enough, then she will go through menopause. And to your point, that doesn't necessarily mean that it will be a horrific experience. Everyone experiences it differently. Some have a lot of symptoms, some have symptoms in the years leading up to it. Some just all of a sudden stop getting their periods, and that's kind of it, right? So menopause really means 12 months, no period. And that's it. It's that one day that it's been 12 months, no period. And so everyone's going to hit it, but it's more about the symptoms, I would say, leading up to it. And then beyond that, can have varying impacts on women.
Now, I'm going to get into your background in a little while, but first, I want to let people know that you could be reached by SheMDNY.com. And it says on your website, Dr. Merrill Kahan, board certified gynecologist, aesthetic specialist, and Menopause Society certified practitioner. What does that last part mean?
So the Menopause Society is a society of menopause providers. So they provide a lot of education for both for providers as well as for patients. So it's really about raising awareness regarding menopause and helping patients get the care that they need. And it helps them find providers who have taken the time to go through this extra certification, that's completely separate from our schooling, our residency, and all that. So anyone who has those initials MSCP, it means that they have taken the necessary additional steps, took an exam, passed the exam, of course, and now they're certified within menopause. They have that extra knowledge specifically in menopause on how to diagnose, manage, and treat women in menopause.
The website's really great. A lot of the things I saw, like for annual exams, it was for abnormal pap smears, abnormal bleeding, vaginal infections, contraception, pelvic pain, irregular periods, pregnancy confirmation, infertility, and just a few of the services, the other services, Botox, fillers, hair restoration, menopause, hormone therapy, sexual dysfunction. Is it a place where women go to get their pap smear, or it's a result of an abnormal pap smear, for
All
example?
the above. So I do gynecology, bread and butter gynecology. That's what I've been doing for years at this point. And while I have done the menopause certification and I do a lot in terms of perimenopause and menopause management, I also do the, I would say, quote unquote, regular gynecology as well. And so people come in to see me for just their routine wellness visit. They'll come if they have, to your point, an abnormal PAP, if they have pelvic pain, irregular bleeding, they think they have an infection, they want to talk about birth control. So all of the, I would say, non-hormonal sort of gynecological issues, though some of those are hormonal too. But, anything from adolescence and up is what I manage.
I want to talk about my mom's situation, and then I want to, after your, I'm sure, very adroit, thoughtful, and compassionate answer, get a little bit more into why you do what you do. Because I mentioned this to my mother, she was really happy about it, and I certainly am too, because I remember her experience very vividly. So my mom, she had early menopause at 40. At the time, her personal life was pretty tumultuous. She would eventually divorce my dad, or they would get a divorce. And I can say that very nonchalantly, because 10 years later, my parents got remarried. She jokes and says it blames it on menopause, which obviously is not necessarily the case. They both had some issues, but she does wonder if the high stress situation might have caused early menopause. She had, when she did get her periods, they were very high flow type of periods. And those are just questions that she has. Her doctor had never mentioned any kind of treatment, which I think is important for people to hear, that, like the hormone replacement and the other treatments that you offer. No one ever mentioned anything like that. It was sort of like that storm analogy, like, hey, the tornado's coming and maybe it'll hit your house and maybe it won't. Good luck. Let me know how it turns out. Does the high stress environment, can that cause early menopause?
I mean, I would say not scientifically, no. I mean, we live in a stressful world, and the age of menopause, 51, has been decreasing. And so while there are certainly causes of early menopause, which I'm happy to get into, just like stress by itself, it's not generally something that would cause like by itself.
Okay, that's good. That's good to know. What are some of the signs of early menopause?
So, someone who has early menopause, so again, menopause meaning you've gone the full 12 months, no periods. So, generally, we think of someone before the age of 40. If that's when they hit menopause, then they're in early menopause. And that really matters because we need our body to continue to make estrogen. Estrogen protects our bones, our brains, and our heart. So if we're going that extra 10 plus years without estrogen, that really is setting people up to have osteoporosis, brain dysfunction like dementia, heart disease, and especially in the past couple of decades where everyone has been terrified of prescribing and using hormones, that just means they've been going for that much longer without the protection of estrogen. Most commonly, reasons for early menopause could be genetic. So I don't know about your mom's history, but genetic causes can be one reason. Autoimmune conditions, if they're attacking the ovaries, that can be another cause. A surgery where you have your ovaries removed, that can be another cause. Or if you had certain medications like chemotherapy. Chromosomal conditions can cause early menopause. So there's a lot of reasons why, and it can be more than one. So, and then there's just idiopathic where we actually have no idea why it happens.
That's really interesting. You said that, losing your estrogen any amount of time earlier than what's normal, having those long lasting effects like dementia or osteoporosis. To that point, if someone experiences menopause, early menopause, there's menopause in general, even years later, say 10 years after, 20 years after, is hormone replacement therapy something you could do even years later?
So if someone's in menopause, then one could argue you don't really have to check their levels. There's different schools of thought in terms of testing in the first place, especially if you're planning on putting someone on hormone replacement. The way I practice, I do test people's hormone levels because I want to know where they're starting and also like how they're doing. But I know sometimes others don't even bother and they go solely based on symptoms. As far as starting hormones years later, we know the safest time is to start within 10 years of menopause. After that time, there could be risks of like heart disease, clots. That's not to say that you can't start it later. You just want to make sure that you're choosing the right candidate. And some people will want to make sure that if you are starting it later, like let's say that average 51, now they're 65 and they want to go on it, they're not going to get as much benefit anymore. And some may say, let's have you make sure you get like a cardiac clearance or a clearance from your primary care. Again, not everyone might do that, but it is a little bit higher risk to start later. And again, you're not getting all the protective benefits as if you had started earlier.
That's an excellent point. For the healthiest outcome, not to go 10 years past when menopause started for the hormone replacement. There was another person, and she had, seen her doctor, and she looked at the chart and it had talked about vaginal atrophy. Is that another result of menopause that can
Yes,
happen?
absolutely. That's going to hit like 50, 70% of women, honestly, and that can definitely start before menopause. I mean, I would see it a lot in much younger women if they were on birth control pills, which lowers their body's natural hormone levels, or if they were postpartum, but you certainly see it a lot during perimenopause. And the reason is, the hormones really work on all of the cells throughout our whole body. So that would include the vagina. So estrogen, testosterone are both very essential for the health of the vaginal tissue. And when you have decreased amounts of those hormones circulating in the body, you're going to get less of those hormones reaching that tissue. So the tissue just becomes less pliable, more friable. It's almost like sandpapery. So it just can be excruciating during intercourse or even wiping when you go to the bathroom. You're just constantly aware of the discomfort. And of course, it's not supposed to be that way. And so even throughout this the past couple decades that I referenced, where there was this fear surrounding hormone replacement therapy, there had still been uh, use of vaginal estrogen therapy. Still some confusion regarding that, which I'm happy to get into. That's a whole topic. And it's a hot debate currently, thankfully, but that is different than hormone replacement because it only acts locally on that tissue.
It seems hormone replacement, like testosterone I know I'm at the gym, and it seems like a lot of guys over 60 have a lot more muscles than I remember back in the day. I had my testosterone checked and it was like at 650. I was like, okay,
Okay.
great. All right. I'm fine with that. It seems now that more of the conversation is the risk of taking hormone replacement therapy, at least on the male end, because now like men in their 20s are trying to get into that. And you have these pop-up clinics. But in terms of females, was this not as popular in, say, the 90s?
I know it was popular in the 90s until 2002, actually. That was before my time. I was in finishing high school. And in
Yeah, me too.
2002, a study came out that basically said hormones are dangerous. They cause cancer, heart attacks, strokes. And so all these women who had been happy on their hormones were terrified, and their providers were terrified and went off their hormones, and they stopped teaching about menopause and hormones to residents.
It's like a lost art and technology for a little while.
Totally. So then, um, what happened since 2002 is that that one study, the Women's Health Initiative, had been looked at many times over, and we know that that study was very flawed because not only did it include or really only studied women who, number one, were more than 10 years out, and we already talked about that, but also used synthetic hormones as opposed to bioidentical hormones.
See.
Bioidentical hormones are, as the name implies, the version that matches what our body naturally makes. and synthetic are just completely different molecules. And so they cause different effects. They can cause inflammation, they can cause disease, they can cause side effects. And so,
Yeah, very important differentiation right
exactly.
there.
So, no wonder we got the results we got. And so, everyone was scared off. And now, all these studies have shown those flaws and shown how safe and protective bioidentical hormones are, especially when you start them within 10 years of menopause or even earlier. I mean, some people, myself included, use some of them in perimenopause. And so now there's this whole resurgence and interest in perimenopause and menopause. And in fact, last week there was an expert panel, providers, mostly physicians, spoke in front of the FDA about how the harm that's been done to women over the past couple of decades by claiming that HRT is harmful, and explaining all the ways that it's not harmful, but in fact helpful and protective. And so TBD what happens, but hopefully that's going to now become the norm and the accepted standard, and labeling will change. The labeling has been scaring off people that it can cause cancer and heart disease and all that. And so that's currently happening right now. And I think that means that, women, unfortunately, a whole generation missed out, but moving forward, that we'll go back to what it used to be like, where a lot of women were on hormone replacement.
And a lot more female physicians in the field. Seems more appropriate when it comes to women's health that there's more women taking care of women, because we know, for example, I work in the ER. We know we miss a lot of heart attacks with females because their symptoms aren't as like male, heart attacks, and that we're commonly more familiar with. And so I think across the board, women are just they get screwed over with that lack of understanding to what they're going through. You had said on your site that one of the reasons for your going into this field is that you found that you felt like many women were feeling rushed at OBGYN, overlooked, and often having their concerns dismissed. I know just from firsthand hearing female loved ones in my family, feeling dismissed. That's exactly what they felt. I think part of this resurgence is that we just have more people like you in this field. And you kind of blew my mind a little bit with the birth control and how, decreasing hormones, even at that level, can cause atrophy. Just a quick question though, because a lot of the conversation I have or I hear is like with males. A lot of males are doing the testosterone replacement, and their whole goal is to lose weight, get gains in the gym, get that nice 1,000 number, between 800 and 1,000. With what you're doing, how much estrogen are you giving? How much testosterone? For guys, there's just that standard number that they want everyone to hit. It might be good for some people, it might not be good for some people. What are the lows that constitute warranting hormone replacement therapy, and what are the numbers that you're trying to attain?
Looking for just one number and wanting everyone to hit it. And, that's one of the downsides, I would say, of a lot of these, as you called, the pop-up shops that are offering it. I think it's a bit of a one-size-fits-all approach, and that's a terrible approach. I'm looking to alleviate symptoms and not put them into the point where they're having side effects, and I don't want them to be in a super physiologic range. So I'm really trying to bring back their levels to where they likely were before they started having their symptoms, before their levels were dropping. I don't treat men, but 800 to 1,000 for a man, I mean, that's pretty high, I would say.
When I talk to guys, their number is like 1,000, 900. They always say that a man in his prime, in his early 20s, is 800. To me, it always seems like not everybody is meant to hit that level. Maybe they weren't even at that level in their prime, but that's one of the reasons why I'm a little hesitant to jump on that bandwagon, especially since once you go on replacement therapy, your body's not making it anymore. So I'm like, why?
Yeah. And that's
Yeah.
for young men, I mean, that's it. Starting on testosterone is they're going to be on it for life. You're shutting down their own production. Of course, you want to think about fertility for them. So, if they're not making testosterone, they're going to face fertility issues if that's something important to them. I mean, it's really important that you know what kind of provider you're going to. You want to make sure it's someone who has had the additional training, who understands all the nuances and tailors the treatment to the individual and not just with the goal of, um, here, we need to give you enough till your lab looks like this, but you really want to know what the person's symptoms are. And, I offer hormone pellets as well, which are little implants of either estrogen or testosterone. And those are nice because once implanted, they slowly release hormones and they last for several months. But, there's some companies that they offer pellets and it's literally a formula you fill out strictly based on lab numbers. And the problem with that again is we're all different and we all process medications differently and we can all have different side effects. And it's really, you want to be careful of looking only at a lab number.
I have this expression for myself. I say labs lie. It's one of the reasons why we recheck things like troponin a couple of times. Or I once brought in my 6-month-old daughter who had RSV at the time to the hospital, and they tried to kind of dismiss her because her labs were fine. And I'm like, she hasn't held anything down in 24 hours. She would later get admitted for 9 days and be put on oxygen. But they tried to hold over like the lab results, like it's like the almighty lab results. And I'm like, you can't tell me that there's no that she's okay, because she's my kid and I'm a nurse, by the way. It's like, I know she's not okay. Like I said, she was admitted for 9 days, but yeah, that's a dangerous avenue and not personalized at all. I think people think, oh, it's my labs. But again, there's a lot we don't know. Labs have to be rechecked. To go just on labs is not individualized
I
care.
mean, we don't really need to get medical training at all, do we? We can just type our
Yeah,
labs
exactly.
into some algorithm.
Are there permanent, like again, going into some of the myths of menopause, someone had told me that someone they knew, it seemed like after menopause, this person was less warm. Maybe there was like a personality change. Can that happen after menopause? Can you be different personality wise?
Well, going back to what you said with your parents and getting divorced, which was blamed on menopause, definitely can see changes in terms of mood that can cause either depressed symptoms, it can cause increased anxiety, it can cause irritability, it can cause just like a short temper. So definitely can impact interpersonal relationships. I'll have patients tell me that their kids will call them out on it, or they're just very reactionary now with their kids. They have no patience anymore, or with their partner. It can impact you at work too for those same reasons. And then sleep often suffers. And when we're not getting enough sleep, we just feel like crap, and that can make us crankier too. Often there's changes with our body habitus and body image, and that really and aging, right? So just how we look, that all like plays into our confidence. And I know that definitely has an impact, at least on romantic relationships. When you don't feel comfortable, you're less likely to be intimate. Forget about, the hormonal changes causing lower libido and vaginal dryness and all that. But I think it all kind of plays into, I don't know if it's so much of a personality change, but more of like these little issues that can absolutely change one's behavior, interacting with others, and their mood.
You were talking about sexual dysfunction, like the vaginal atrophy, or like you said, the walls of the vagina could be like sandpaper. So if you're not enjoying sex anymore, if you're having a low, less of a regard to your physical appearance, your mood is going to change fundamentally, your behavior patterns, how you're coping. I could definitely see that as more of an effect. How did you get into this field? What drew you to women's health? I mean, aside from the fact that you're a woman, was it somebody personal in your life, or just too many times you saw, like maybe you yourself, you felt dismissed?
I originally got into OBGYN. That was when I went into med school, the one field I knew I didn't want to do because I wasn't waking up in the middle of the night to deliver babies. So it was my last rotation, and it was the one I liked the most. So then I practiced OB along with GYN for several years. And then I opened up my own practice, SheMD, less than 2 years ago. And at that point, I knew that based on my experiences thus far, I felt completely unqualified to take care of women in perimenopause and menopause. I would just give them a prescription for birth control or sleeping pills, and my colleagues did too. I mean, it was just like there's no time to do anything else. With the insurance model, you have to rush through your 15-minute visits, but we also, like I said, didn't really have the training to know what to do, and we just thought hormones were dangerous.
Yeah,
So
that's that. Not to cut you off, but that's part of the whole the daunting that regular people have, like when it comes to the subject, like again, that storm, like here's a life raft or here's some food and water. It's like you don't know how to deal with it. You don't know how to approach it. You don't hear about a lot of the more nuanced treatments that you were talking about.
well,
Um,
how detailed you really get when you're in like a 15-minute visit. I mean, there's really the two components. There's that and our misinformation, miseducation, whatever you want to call it. And so when I did the menopause certification and the hormone training and all that, because I knew that in giving those subjects, I really want to be able to focus on helping a different subset in a way that had seen that most people can't do that. I mean, there's plenty of people delivering babies, and there weren't as many helping these women who were just being like dismissed and neglected and all that. I think I started that literally right before I would call it the menopause boom when everyone became very interested in menopause and it became a hot topic in the media.
my wife and I had mentioned that where there's a lot of conversations about becoming pregnant and going through a pregnancy, but as soon as you hit the postpartum period, it seems to kind of just drop. And of course, menopause is even worse in terms of conversations about that subject. So that's one of the reasons I wanted to talk to you today. Do you find a lot of the women that come your way, there's never been a in-depth conversation about what they're going through or what they will go through?
Oh my goodness, yes. A lot of women coming to me that will say they've been with their OBGYN for years and they love her. Just at the point they're just frustrated now. They're trying to talk to them about what's going on with them, and for whatever reason, like either they're not fully in menopause yet. Talk to me when you're in menopause. Oh, here's some birth control. Oh, you're fine. Like, uh, and so yeah, they're just getting to the point where now they're finally demanding that someone listen to them. And if they're not finding what they need, then they got to go somewhere else. I mean, it's great that more people are getting the menopause training, but not everyone's equal, I would say. For menopause management, I do virtual visits, which, it lends itself to that for the most part, but I'll do that throughout New York. And then I also have virtual medical license or telehealth license for Florida. And I'm working on a few other states as well.
And you could do replacement that way, hormone replacement?
Yep.
What effects does estrogen and testosterone have in women's health?
That's a great question. And I'm going to add one to it, the progesterone. Estrogen, the one that we always hear about. And as I mentioned earlier, it's very important for things we don't even notice. So our bones, our heart, and our brain. It's also important for our mood. It's important for our skin, for vaginal health. It's important, when it's low, that's when we can have the hot flashes and the night sweats and all that. And then the testosterone is more of our motivating hormone. So it can give us energy, it gives us motivation. It helps with our muscles. It helps with libido, of course. And then progesterone is our calming hormone. And so progesterone really comes into play when women are having difficulty sleeping, when they're having the anxiety and irritability. So progesterone helps calm everything down, and it also balances estrogen. And so One of the things that estrogen does, as I mentioned, we have receptors to these hormones throughout our body. So in the uterus, estrogen promotes the growth of the lining of the uterus. And what can happen over time is if the lining continues to grow unchecked, it can lead to issues like bleeding, but it can lead to abnormal uterine cells and ultimately uterine cancer. And progesterone has the opposite effect on the uterine lining. So progesterone is necessary for anyone on estrogen to protect the lining of your uterus. And so a lot of providers believe that if you don't have a uterus, if you've had a hysterectomy and you're on estrogen, you do not need progesterone because you don't need that protection.
Oh, I see what you're
I
saying.
am not that provider though. And I believe probably everyone needs progesterone for those other effects, for the calming effects, to balance the estrogen. It helps with the sleep, it helps with the mood. And I have people on progesterone who don't even need estrogen yet. Our progesterone tends to drop even before our estrogen does. And so, there's some overlap, and it's a matter of balancing those three out with each other. But that's a general overview of what they do.
Yeah, that trinity you just mentioned, the progesterone, estrogen, and testosterone, you just described like the perfectly balanced human being when all of those levels are where they should be. And I can't imagine any kind of hesitancy to not want to engage those three when they're out of whack. It seems so obvious that somebody would be quite uncomfortable, imbalanced without those levels being, normal for that person. I just remember my mom, this one moment where she was going through it, and I just remember that she screamed to herself. Like it was like really kind of heartbreaking to think about it, just how alone she felt at the time and isolated and imbalanced. And that's why I really wanted to have this conversation, because I feel like it's what you were describing. You go to your doctor, you have your 15 minutes, you probably don't even remember half the questions you wanted to ask. And then you head out of there and you don't know what's available to you. And it's not like you could just make another appointment to have a chat.
I had someone like the other day tell me that she didn't know if her doctor had given her a prescription for hormone replacement or birth control.
Oh, wow.
Yeah.
Yeah, a lot of people, they come into the ER and they don't know what medications they're on. What is the difference between giving someone birth control hormones and estrogen?
First off, the hormones are different in that birth control, they're synthetic hormones. They're not bioidentical hormones. And number two, the doses are way different. So actually, hormone replacement therapy, menopause hormone replacement therapy is much lower doses than birth control.
It's just talking to you. It's just reminds me like nothing is for free. You take birth control, but there could be a horrific side effect to that. Or if you just take anything without a properly measured and personalized dose, it could lead to other adverse effects. How is this going so far for you? Is there anything I haven't touched that you wanted to touch on?
You should
This isn't my forte, my field.
we should touch on, if it's okay, how the insurance model like just gets in the way of being able to provide good care for menopause.
Yeah, that was in the back of my mind. I was trying to think of a way to do it without dumping on the entire industry,
No, you
because
can
boy, I
dump.
can tell
You can dump.
I could say so many things
I'll
about
dump. I'll dump.
my frustrations about it, trying
You
to help
should
people and
see
then having to.
the emails that I've written.
And I know a retired spinal surgeon who, the hospital hired a third party, and it was like a watchdog group. Like, why did you spend $500 on, this pain medication or whatever it was? And it was like, because the patient is in a lot of pain. Like just nitpicking every little
Well, then we
figure,
should talk
you
to the
know.
pharmaceutical industry of why it would cost $500 to need
I know.
medicine, but that's a different
Well,
thing.
that's the thing I always find is like our concept of what profit is. It's like if you have to upcharge 300% to consider something a profit, that's the sickness. Like what counts as a profit? I feel like, we can't sell something that costs $1 for $4 or $2. We need to charge $27 or $25. So if we make $18 on something that costs $1, that's a profit loss. Like, it's kind of nuts that the system, I mean, it's kind of an oversimplification of it. But
Ma-
so let's dive into how the insurance companies, that whole system plays effect into what you're trying to do.
So insurance, I think, everyone is noticing at this point is a mess. And what's happening is that people's costs and premiums are going up year after year. And what's actually getting covered is going down year after year. And additionally, what doctors are getting reimbursed is going down, and yet costs of doing business are going up. And so that really creates a problem because if doctors can't afford to stay in business, then there will be no doctors to take care of you. And with reimbursements going down, that means the only way in order to cover costs, let alone make any sort of living, is to see that many more patients. And so what happens, you have a revolving door of patients and you have like 7 to 15 minutes per appointment. I think we can see how important when we're talking about menopause care and hormone replacement, that is just not one size fits all. You really need to get into someone's history. You need to know what's going on with them. You need to know about their lifestyle, family history, risk factors, and all of that. And then you need to be able to do certain testing, and you need to come up with a personalized plan for everyone. And you need to be able to check in with them and make little tweaks along the way. And it's simply not possible. You cannot do that when you have these time restrictions in order to see so many patients to keep the lights on in the office. And so that's why a lot of menopause providers are out of network because they simply cannot get good results with that sort of time constraint. And then in addition, I know everyone thinks like doctors are greedy, doctors are greedy. Well, we're not greedy, but we do need to make money in order to keep our businesses open so that we can take care of people. And it costs a lot of money to maintain a medical license, honestly. It's simply not possible to provide that level of care within an insurance model. And listen, do I know some doctors that are charging obscene amounts of money for this? Yes, I do. Is that necessary? I mean, I'm not going to really comment on that, but there's definitely a spectrum um, outside of the insurance world in ways that are very affordable for patients. And you have to look at it too, like this is an investment in your health and in your longevity and your well-being. And it is a medical issue. I mean, it does prevent a lot of illnesses, but it's also a quality of life issue.
It's interesting because it seems like I'll just say from a nurse's point of view, there's a much bigger push on how to care for somebody in an individualized way, like introducing such like community health, for example, which I think is so important. But then when you actually start getting to the floor and taking care of people, it's very systematic, even more than it's ever been. So it's conflicting in your training because you're trying to recognize people, their backgrounds and why they're coming in and what they've been doing, but you're given less and less time to actually do that.
And I think insurance, you have to go through protocol. You have to check like certain things before you can get to the next thing. And I mean, I think ultimately that wastes more time and money. But yeah, so it is harder to have a more personalized approach when you're just forced to do like the same thing on everyone.
In terms of like the hospitals and the insurance companies, they've already had their private conversations with the administrators and all that. On the topic of the hormone replacement on your website, because you have blogs on your website that I thought were very interesting, and one of the blog topics was weight loss and hormone therapy, and it just made me think about, for example, in my experience in the ER, we don't even talk about nutrition, and that could be a whole different podcast on the lack of conversations had about nutrition. And it just seems now the approach is to put everyone on a GLP-1 receptor agonist and just not even talk about nutrition, just, take your shot and lose weight. The problem with that is a lot of studies are showing that you lose a lot more lean muscle mass than you would if you were going to the gym or doing what you can in terms of fitness and eating right and whatnot. Do you find, like, as women are getting older and they're dealing with weight gain, that one of the important reasons to get checked is because you might be taking that GLP-1 receptor agonist to lose weight where it's really just a hormone thing? Do you find like situations like that are happening?
For GLP-1s, I mean, I think pop-ups are doing them
That's
for
yeah,
everyone.
exactly.
But I really like to limit their use to those who meet more of the medical criteria. So they need to have a certain BMI or certain medical conditions, BMI greater than 30, you know, based on that alone, they would medically qualify. So would that person lose much weight on just hormone replacement therapy as they would so? Being on hormone therapy can certainly alter your body composition, and it can make you so now you're actually motivated and you're working out and you're eating better and all that. There's also a study that shows that women who are on both a semaglutide and hormone replacement therapy lose about 30% more than those on semaglutide alone. There are definitely positive changes to one's body and body habits that happen on hormone replacement therapy by itself. But nothing has been shown to be as effective at weight loss as the GLP-1s, especially as tirzepatide.
I just hope in the future, it doesn't turn out that the GLPs are removing too much lean muscle, because obviously that's
Well,
something
I mean, you have
that
to
is
be
quite
very
important.
careful. It's not like a magic drug. You can't just take it and think everything's going to be good, right? So that has to be part of the counseling. It has to be that you're talking about the protein intake and the weight training, the resistance training. That has to be part of being on the GLP-1. Like the lifestyle is both for while you're taking the medication so that you are retaining the muscle mass, and also for if you do go off of it so that you're healthy once you go off of it and you don't just regain back everything with a vengeance, which
Yeah.
we're seeing people do.
Yeah. And it has to do, again, what you said, the follow up and how much time you're spending with your physician who should be guiding you through that whole process. Usually when I have guests, like I said, this is one of those subjects where, I did my due diligence, but again, I'm not in this field at all.
No,
So
I think it's so great that you talked about it because, as we said at the beginning, just everyone has females in their lives in some capacity, and every female is going to go through it. So just having an understanding about it, I think is very helpful. So they're not just like, oh, you're crazy, hormonal, whatever it is, dismissing them, but actually gets what's happening.
yeah, and just some of the things you had mentioned in terms of atrophy from lower to estrogen because of birth control, or some of the options that people have. It really helped me personally because my wife isn't there yet, but it just gives me something to think about for when we do get there.
There's a lot of
And
options. Yeah, there's a lot. Yeah.
yeah, that whole metaphor of it's a tornado, it'll hit you, maybe it'll take your house, maybe it won't. That's just not true. You don't have to feel so powerless about this time of your life. Thank you for what you do. All your information will be in the description. And this is your website, shemdny.com. I recommend everyone take a look at that because it's really helpful. All the context that one might need is in that website. Look up Dr. Kahan, read the blogs, check out what she does. But thank you, Dr. Kahan. Thank you for doing this.
Thank you so much.
I normally sign off when the guest does, but I just wanted to remind everyone to please like, share, and subscribe. It really helps the channel out against the algorithm. The algorithm decides who sees what, even if you're subscribed to the channel. So please share, you show some love. And in terms of this podcast episode, menopause, and this time of a woman's life, send it to somebody who may need it. We had a very short, nuanced conversation about this period in a woman's life. Every woman is going to go through it, and every woman has options. You don't have to feel isolated and alone. You don't have to feel like there's nothing for you. Go to SheMDNY.com, do your research, and reach out to Dr. Kahan. There are options, and it seems like from this conversation with Dr. Kahan that there are a lot of options. At the time that I'm recording this podcast, I will be working a night shift tonight. It's a 2-month contract. I am a local travel nurse. And if you have any questions about travel nursing, hit me up. If you're thinking about going to boot camp, if you're going to be a future Navy Hospital Corpsman, hit me up. If you're a corpsman and you're thinking about attaching to the Marines, hit me up. Hey, if you just want to chat about anything, hit me up. All right. But stay hungry, be humble. I hope you enjoyed this conversation I had with Dr. Kahan. Nurse Data.